Our second talk today addresses a topic that is both common and commonly misunderstood. Despite abundant sunlight, vitamin D deficiency remains highly prevalent in Pakistan, and at the same time, myths and misconceptions continue to influence testing and treatment practices. To bring clarity and evidence to this subject, we are pleased to invite Dr. Tabinda Dugal. She's consultant endocrinologist, NHS UK. She's also chapter head for our very recently launched Qatar chapter. Ma'am, please take over for your talk. Thank you.
Assalamu alaikum. Assalamu alaikum. Thank you very much for the kind introduction, and I'm really honored to be here this morning. I just wanted to talk about a little bit about vitamin D, a little bit about its science behind it, and how people have been using it and how it could probably be better used. So a little bit about the history of vitamin D. So it was first, when rickets was realized in 1918, they didn't know what was causing the rickets, and they thought it was vitamin A. And they were labeling the vitamins, so the A, B, C kind of ended up in D, and they found that it wasn't vitamin E, it was vitamin D. And then they made the UV connection, that it was being made in the skin through UV light in 1923. Then around 1930, the structure of vitamin D2 and D3 was discovered, and then the metabolism in the 60s, and the vitamin D receptors were then discovered in 1970, and it was upgraded to a hormone rather than a vitamin. So it has come through a long way, through almost more than a century. Why does it still matter? Because we know what dose to take, what it does, and why are we talking about this? So first up, it's a hormone, it's not a supplement. So it works in a different way as compared to other vitamins. Lots of people are deficient in it. So it has superseded the iron deficiency, and vitamin D deficiency is the most common deficiency that is around in the world in micronutrients. There are some randomized controlled trials that have changed our practice, and I will go through those as well. So before, which was the observational era, when we did not have those trials, low vitamin D was associated with cardiovascular disease, cancer, diabetes, fractures. And the assumption was that supplementation would prevent these issues. And the practice was widespread testing of vitamin D levels and high-dose bolus uses. However, after the trials, the randomized control trials, of which I have a few here, there's a VITAL trial, VIDA trial, D2D trial, and Sanders trial as well. So all of these have shown one or the other conclusion. They were fairly recent trials, and this showed that there was no CV or cancer benefit, cardiovascular or cancer benefit, from 2,000 international units per day. With a higher dose of 100,000 international units per month, there was no cardiovascular or fracture benefit. And also with 4,000 international units per day, there was no diabetes prevention, which was thought to be one of the events that would be prevented by it. There was also no risk reduction in falls or fractures. However, in the very frail, it did reduce the falls, but not with the high dose. So why does it matter how we sit in the sun and how our skin absorbs? There is no race element to it. There's a pigment element to it. So melanin is the one that makes the difference. We do have the Fitzpatrick scale, and I believe that in Pakistan, most of the people would be between Fitzpatrick type 3 and Fitzpatrick type 5. So they would need between 30 to 45 minutes a day of about 3 to 4 times a week, depending on what skin type is. So usually it is a lot more than we can spare our time for. And this is a cartoon showing that all the conversion happens in the epidermis. The UVB light goes to the epidermis, where we get the conversion into metabolites, and then 25-hydroxy vitamin D, and then further conversion in the liver, and then in the renal. But our own melanin pigment works as a sunscreen and doesn't let things happen. We also have non-availability of the appropriate UVB because of environmental pollution and lack of those particular type of sun rays. So as I said, it is absorbed from the skin, goes to the liver and kidney, and we have the vitamin D receptors, and we have the 25-hydroxy vitamin D, which is the status marker. So when we measure, we are measuring this. And the active hormone is obviously the last product which is converted in the kidney. That's 125-hydroxy vitamin D. The regulation of activation is obviously through parathyroid hormone, which upregulates it, and the FGF23, which is produced in the osteoblasts or the osteocytes, it reduces the activation through the Klotho gene in the kidney. Also, if a patient has chronic kidney disease, it also disrupts the pathway of activation of vitamin D. The VDR is a very unique receptor. It is not found on the cells. It is in the nucleus, and therefore it has to be carried, the vitamin D has to be carried to the nucleus. And these it forms a heterodimer with RXR, which is retinoid type carriers, and then it binds with VDRE, which is then located on the DNA to make those changes in that particular cell. And it's very unique in the fact that it can have different actions in different organs on the body. So the calcitriol, which is the final product from the kidney, goes to the vitamin D receptors, which is the VDR, and it then forms the heterodimer with RXR, binds with VDRA on the DNA, and then does the gene transcription. So it has got a very unique way of action. So there's about 1,000 to 2,000 genes that are controlled by vitamin D and affected by the level fluctuation. So this is about 4 to 5% of the genome, of human genome. So this is a wide number of genes that are affected. And they could be in the bone, in the muscle, they could be in the immune system, or in metabolic and reproductive as well. And to explain these is slightly, I think it's slightly difficult to explain each one of them, but we will try and quickly go through all of them. So we have these genes, if in deficiency of vitamin D, these are downregulated, and therefore there is low calcium absorption. Osteocalcin, osteomalacia when it is downregulated, and it's also insulin-like growth factor is downregulated when there is low vitamin D levels, and there's myopathy because of that. And of course we get secondary hyperparathyroidism to try and regulate the vitamin D, so there's increased parathyroid hormone-driven resorption. If there is too much vitamin D around, which I think a lot of people are taking overdoses of vitamin D, we obviously get upregulation of calcium absorption genes. We have rank ligand imbalance. We also have upregulation of FGF23. And there is actually no physiologically off switch. So people can overdose with vitamin D and nothing switches off these upregulation. So it's quite dangerous to have overdose of vitamin D. And what about obesity? We talked about obesity this morning, and a lot of patients who are overweight or obese will have lower levels of vitamin D. And this can happen through a couple of mechanisms. One of them is that it is a fat-soluble vitamin, so it will be sequestered in the fat. And the other one is that because of the body mass, the vitamin D will get diluted, and the measured levels would be low. And these people respond poorly to vitamin D replacement, so they generally need larger doses of vitamin D for replacement. And vitamin D receptors are found in the adipocytes, and because the ligand that binds it works through PPAR, leptin, and aponectin regulation as well. So there is also a concept in people that if you supplement vitamin D, you may lose weight because of the sequestration and all that, but that is not true. Actually, if patients lose weight, if people lose weight, they will have higher levels of vitamin D. So it has no connection with losing weight if you supplement vitamin D. What about fertility? I think because as ART, assisted reproduction, is becoming more and more accessible to people, this is also important to know that there are receptors in ovary, endometrium, placenta, and testes. The genes that are regulate the anti-Müllerian hormone, the HOXA10, which is on the endometrium, and the CYP19A1 gene as well. And these are, the HOXA is important in implantation of the fetus. So they're all quite important. So the patient who's going for ART should have vitamin D levels that are within range, required range. So I will briefly talk about the desired range, and I digress from the current slide. The levels that were suggested were way back in the last century, and they were to prevent osteomalacia and rickets. And they were rather low, so they were like about 40 nanograms per mil. But actually, the suggested levels are about 120, at which the body would feel that it is doing the function correctly, and none of the genes are up or down regulated, and they're doing their right job. Also, a very common condition, PCOS, about 25 to 30% of young women have PCOS. Lower levels of vitamin D are common in those people as well, and it has a link with insulin resistance, so the higher the insulin resistance, the lower the vitamin D levels would be. There's a modest benefit of supplementation, and therefore it should be considered in such women. And again, going back to the vitamin D and ART and IVF, there is an implantation association, so patients who have lower levels of vitamin D would find it hard to have successful ART. The live birth data is inconsistent, but we do know that ART becomes more facilitated if the vitamin D levels are running to normal levels. We do have to correct the deficiency if found. Best way to take vitamin D, and I think this is very important. This was one of the reasons why I'm talking about it. Daily dosing is the best way to go about it. So about 1,000 to 2,000 international units per day is fine. With meals containing fat because of better absorption, avoid bolus injections. They are not the right thing to do, and they actually have been shown to cause harm. The vitamin D toxicity, which people bring upon themselves by taking large boluses every couple of months, will cause hypercalcemia, nephrocalcinosis, and it is mostly iatrogenic. And as I said, there is no off switch for that, and the toxicity continues. And what about taking vitamin K with vitamin D? And I think this is also a very fashionable thing to do. So basically what vitamin K does is it puts the vitamin D in the right compartment. So it doesn't let it stay in the blood, it puts it in the right compartment. However, this is theoretically proven. We do not have any trials to prove this. So for now, I think we would take some vitamin K to support the vitamin D, but not very large doses. And there are a certain number of people who cannot take it, and I've mentioned them in a minute. Because the vitamin K activates the osteocalcin, and therefore it puts it in the right spot, which is in the bone rather than staying in the blood. There's vitamin K warning because people who are on warfarin or anticoagulants obviously shouldn't be taking vitamin K. It will cause iron instability and it will interfere with the warfarin. So what's the context and what's the relevance of talking about this? Having the sun doesn't equate to having the proper UVB rays. And because of the environmental pollution, we have deficiency of sunlight despite having sunlight. So this is important in women who are going to be breastfeeding or are having children or are contemplating to get pregnant. And adolescent girls, they would be at high risk and they should be considered supplementation and should be identified. Fortification is important in milk and bread, etc., as it happens in certain countries, but I believe it's not happening here. So I believe we had the dose wrong all this time, and I think at the moderate dose is okay. And the concept that more is better, and the sunlight is just enough, so if I sit in the sun for X number of minutes, it's enough. Everybody needs to supplement vitamin D, but it has to be done in a moderate dose. And doesn't cure infertility, so this is one of the myths that goes around it, that it cures infertility. It does not do that. So the take-home messages today, it's a hormone, it's not a vitamin, it's a powerful chemical. We should treat deficiency, not numbers. So the patient comes with a level of vitamin D and says, I think I need, but you need to treat deficiency, not actually go by numbers. So retesting doesn't mean much. You need to balance over rather than giving them extra amounts of boluses. And this is all I had to talk about. Thank you.
Thank you very much, ma'am, for this wonderful talk and for very generously giving us some of our time back as well. We conclude this plenary by focusing on acute medicine, an area that sits at the front line of hospital care and continues to evolve rapidly. As patient complexity increases and health systems face mounting pressure, acute medicine must adapt in structure, training, and delivery.